Hi, this is Dr. Jeff Calhoun. I want to thank you for taking the time to listen to this case presentation on a patient that we used ERG testing. I practice in a group private optometry office in the suburbs of Buffalo, New York. We have a very medically oriented practice, seeing a lot of glaucoma patients and macular degeneration patients and diabetics. Seems like we're having more diabetics every year as our patient base ages. We all know that the majority of diabetic patients will eventually show retinopathy. We brought in the RETeval in April of 2023 to help provide the best eye care for our diabetics patients in particular. The RETeval has definitely helped with patient education, as well as simplifying our decision making on patients with retinopathy. Grading retinopathy can be somewhat difficult and very subjective at times. Has the retinopathy worsened? Has it stabilized? Is it better than last year? So it's great now to have an objective functional test that removes some of that subjective nature grading retinopathy. The RETeval ERG diabetic test is quick. It's performed by a technician in our office. It's easy on the patient to sit through. It's portable and it's highly reliable and repeatable. It's definitely helped us feel more confident managing our patients with retinopathy and helps us decide which patients should we monitor on our own, which one needs to be referred to a retinal specialist and how quickly. And it's helped with patient education, as the patients know their diabetic retinopathy score, and they tend to ask from visit to visit how it compares to previous visits, similar to patients asking about their IOP or their axial length on a myopia management patient. Every morning, our docs review the charts for the upcoming day, and we try to flag what diagnostic tests need to be run by our techs prior to seeing the doctor. This greatly makes the day more efficient when we're ordering a lot of OCTs, visual fields, and ERGs. The case study I'm going to present is probably pretty similar to patients we all see every day in our office. It's a long-term diabetic patient who has fairly well-controlled blood glucose over the years. On face value, it's not a very exotic case, but it gets more interesting after the ERG reveals that the retinal function and visible structural problems are not matching. This is a patient that I saw for the first time. However, she had seen my associate doc for the last 30 plus years. She's been a long-term diabetic for over 20 years now. She denied any other systemic health problems. She was taking some oral diabetic medications, did not recall her last A1C test result, but she stated that her doctor overall was quite happy with a blood glucose control. She'd been previously diagnosed with mild non-proliferative diabetic retinopathy by the associate doc. Her only complaint year after year was she had a hard time seeing at night, especially when it was raining. However, she always declined cataract surgery as she was afraid of surgery and preferred just to avoid driving at night. Entrance testing was unremarkable. The patient did have relatively small myotic pupils that were sluggish upon testing. There was no APD, however. Manifest refraction did improve vision to a very fuzzy 20/30. By microscopy was remarkable for dermatochalasis of the right upper lid and left upper lid. And she did have some fairly brunescent cataracts, which would easily correlate with decreased vision at night. Our office performs optomaps on virtually all of our patients. You could tell on the scan that the patient's dermatochalasis was making the view difficult. Not a great image of the retina, but if you look very closely, you could see a couple scattered dot and blot hemes in the retina of each eye, previously diagnosed by the associate doctor. I ordered a ERG DR test to be performed by my technician on this patient prior to being dilated. Review of the scan shows a severely reduced implicit time in the right eye and the left eye, indicating significant cellular stress in her retinas. Pupil testing was also abnormal, showing very little reaction to light, which is not unusual if the patient has significant iris ischemia from long-term diabetes. The DR score on top is a number that's calculated by the RETeval algorithm, which combines the implicit time of the patient's better eye, the amplitude score of the patient's better eye, the iris functioning of the patient's worse eye, and the age. The test came back with a 26.6 DR score, which is significantly out of the normal 7 to 23.4 range, indicating significant retinal pathology. Any score above 23.4 shows the patient is at 11 times greater risk for surgical intervention in the next 3 years, excuse me. The patient was then dilated. Dilated fundus exam proved difficult. The patient had significant dermatochalasis, which made the view difficult. The cataracts were brunescent. It was hard to see the retina. However, I only saw a few scattered dot and blot hemes. Due to the patient's RETeval score, I was assuming I would find a lot of exudates or signs of any type of occlusion or macular edema, but all I saw was some trace macular RPE changes. There did not appear to be any gross retinal abnormalities. I ended up referring this patient to a retinal specialist for a consult just to help determine why the patient's RETeval DR score was so high. Looking at the patient's retina, I only saw a few scattered dot and blot hemorrhages, but due to her lack of cooperation during the fundus exam and the fact that her lids were so droopy, I honestly couldn't say that I got a great view of the retina. I did not want to miss any type of severe retinopathy. We ended up getting a report back from the retinal specialist 2 months later, which showed that after a fluorescein angiogram was performed, the patient had a very large foveal avascular zone in each macula, as well as diffuse severe capillary dropout in both retinas. This severe ischemia puts this patient at risk for retinal neovascularization in each eye. This is a patient that for many years we just told the patient that she had very mild retinopathy and that she was doing great and that we would just see her in a year. I easily could have said the same thing to the patient after the visit in my office. Without the ERG test performed, this patient could have been sent back to my office in 1 year and had some severe ischemia developing to neovascularization over the year, causing severe vision loss. The patient is going to be monitored very closely over the next couple of years by the retinal specialist. So I find this patient case very interesting. She did not have many visible structural signs of retinopathy during the fundus exam, and which now makes sense. The patient has such severe capillary dropout that she's not going to develop microaneurysms, which end up turning into the dot and blot hemorrhages that we'll see during their exam or during the optomap scan. Without doing the ERG DR test or without running an OCT angiogram, we would have easily continued to underestimate her diabetic retinopathy. This could have led to severe vision loss if the patient ends up developing neovascularization. We could have easily have told this patient, just, you're doing well with your retinopathy, it looks stable, we'll see you in a year. Whereas this patient actually should be monitored very closely for development and neovascularization. And it's also important that we don't overpromise the patient that if she ends up having her cataract surgery, that her night vision will return to normal. This patient may still have significant night vision complaints due to the level of ischemia. This case is another example of why my office tries to run a ERG test on as many diabetics as we can. It's important to get functional data to try to correlate with the structural data. I thank you for your time. I hope you found this case interesting.